All right, good afternoon, everyone. Welcome to Neurology Grand Rounds. I have a couple announcements. So the residency program is expanding, so we have an extra PGY2 spot, and we made an offer to somebody, so hopefully we'll be able to expand next year. I'm also told that there is a happy hour at AAN next week. It's at 6 p.m. on Tuesday. If you want to hang out with Ina, just email her. She'll give you the information. Another thing is we have a visitor from UCLA who is coming here to interview for the neuromuscle position at the VA. Her name is Nashid Jamal, and so hopefully everybody can get to talk to her. Also from UCLA is our next Grand Round speaker. Next week we don't have Grand Rounds for the AN, but the week after Susan Perlman's coming and she's going to talk about ataxia. And that should be really exciting. And the last thing is that we're recruiting people to help run Grand Rounds. So if you have any ideas or suggestions, please let us know. And if you want to volunteer, you should definitely volunteer. It's a great job. So today I want to introduce our speaker. Our speaker today is Brett Stacey. He did his medical school at University of Michigan. He did his fellowship in anesthesiology and pain management. He did his anesthesiology residency and pain management fellowship at the University of Pittsburgh. He has spent a lot of time at OHSU, where he was a professor of anesthesiology and perioperative medicine. He was also the medical director of the comprehensive pain clinic at OHSU. We were lucky enough to recruit him here to the Department of Anesthesiology and Pain Medicine. So it's about a couple months. Is that right? December, yeah. He's been professor of anesthesiology and pain medicine, and he's also the medical director of the University of Washington Center for Pain Relief. And his title today is Neuropathic Pain Overview, Guidelines, Databases, and Procedures. So thanks for coming.
Thank you. Thanks for coming. Thanks for inviting me, I should say. There's not tons of you, and if you have a question or I'm bothered you by something I said, don't wait till the end. Just get my attention. Let's just address it right here and then. I don't care if I get through all the slides or not. I think it's more fun if we have a discussion about things. And we come from different backgrounds, right? You're a neurologist. I'm not. That's my biggest disclosure in a minute. So my goal is to kind of talk about neuropathic pain a little bit, give an overview, look at treatment guidelines and treatment options, look at the kind of gaps that our evidence-based medicine leaves us with, and talk about how we can kind of fill those gaps, and then talk about some treatments that we have to offer at the Center for Pain Relief. So my disclosures, first ones are the kind you always have to disclose, right, which is that I'm a consultant researcher for Teva Pharmaceuticals, developing a phase 2 drug. I've done a bunch of other things in the relative recent past. And the big one is, of course, I'm not a neurologist, so I don't know as much about a lot of these things as you guys already do. I have other conflicts. I spend most of my days seeing patients, and my preference is to see patients with neuropathic pain. I like these patients. This is my favorite patient population. I will definitely express some opinions, and my ramp up at UW and kind of learning the culture here has been a little slower than I thought it would be. So those are my disclosures. So if I look a little frustrated, that's that part. So everybody has a different definition of pain. This is not a very neurological definition of pain, right? So this is the kind of thing that we've all experienced some version of. Maybe not quite this dramatic, but it's tissue damage. And pain is a sensory and emotional experience associated with tissue damage, or it certainly feels like something's broken. And so when a patient's talking to you, that's what they're kind of conveying to you. There's something wrong with me, and it has an emotional impact on them. Ongoing pain is kind of a different thing than the acute setting. Ongoing pain starts impacting all parts of a person's life. And there's many different definitions, and I actually think that this one from the American Society of Anesthesiologists is one of the better ones, even though it's very wordy and a little clunky to say. It's pain associated with a chronic medical condition or extending beyond the period of normal expected healing, and it adversely affects the function and well-being of the individual. So it isn't just, oh, that pain doesn't do anything. It's pain that does something. That's a chronic pain condition. And we all know from seeing patients with chronic pain, it's not just the pain, it's not just the sensation of tissue damage, but a lot of other things come along with that. Patients get less active, they get deconditioned, they may gain weight. It makes them more injury prone, they're less likely to protect themselves well. They can have altered mood. They're not just depressed. As you well know, if you've seen very many patients, some of them are very angry and irritated. Some of them are very anxious and nervous. There's a whole variety of emotions that can go along with chronic pain. The majority of patients with significant chronic pain have poor sleep. Many report loss of energy, loss of libido, work and vocational difficulties, legal issues. They may have financial concerns and family stresses. May feel like they don't know what the meaning of the world is, how God thinks of them, what their role is in their family. All kinds of things come up when you have chronic pain. And so when you see someone with chronic pain, it's important to kind of think about those things. And to think that that kind of can take on a life of its own. In fact, Institute of Medicine was not the first to come up with this idea of endorsing it as a disease, but definitely endorsed it in its big landmark report 4 years ago. This landmark report basically said that pain costs the U.S. economy billions of dollars per year. It's poorly treated. We don't do a very good job with it. We need to do a better job. Maybe one way of thinking about doing a better job is to think of it as a disease in and of itself, specifically chronic ongoing pain. So if someone has ongoing pain, almost regardless of the etiology, it has certain commonalities between the different kind of chronic pain conditions. So that's background. Now we move on to more interesting stuff, neuropathic pain. The definition for neuropathic pain has kind of evolved in the last few years. And I will tell you that the primary impetus for the definition changing was neurologists' fear of fibromyalgia. Because when people started figuring out that the somatosensory system was kind of working differently in fibromyalgia patients, and they could see fMRI changes, and they could see changes in the dorsal horn of the spinal cord, fibromyalgia, that sounds too much like a neurological condition. So the neurologist said, how can we keep fibromyalgia from becoming ours? We don't want it. I swear this is the way it seemed to work when I was at these taxonomy meetings. So they thought, here's an idea. We're all about lesions. So if someone has neuropathic pain, they've got to have a lesion. They've got to have a disease. And it has to affect the somatosensory part of the nervous system. They've got to be able to see it or document or prove it for us to count. So that's kind of the basis for the new definition. Pain caused by a lesion or disease of the somatosensory nervous system. So if you don't have that, it's not neuropathic. And then there's a whole bunch of other stuff that people talk about in research settings, which is a grading system. Definite, probable, possible. And definite means you have to have some sort of objective test that demonstrates the lesion that correlates with the pain area. So what this means in English is that it's pain from the nerves, the spinal cord, the brain. It's not from the muscles, skeletal system, internal organs. So it's some stuff you guys care about, not stuff internists care about. Some big concepts about neuropathic pain. The pain is not caused by the nerve damage. Nerve damage does not correlate with people's pain intensity for the most part. Pain is caused by abnormal physiology. It's an additional gift on top of the damage. The damage gives you deficits, abnormal physiology gives you pain. No test can tell us if a person actually has pain or not. They may be able to quantify lesions, deficits, problems, but they really don't tell us about pain. The other thing that's interesting is that the sustaining area for abnormal physiology may be quite removed from the site of original injury. Classic example, phantom limb pain. Phantom limb pain is pain in an absent body part. What starts phantom limb pain? Losing the body part. That's a peripheral problem. Tons of data says that phantom limb pain is a cortical phenomenon. So it's nowhere near the lost body part. It's a cortical phenomenon. So the physiology that sustains the abnormal pain may have nothing to do with the inciting lesion in terms of location within the nervous system.
So is that considered your definite or your possible or your probable phantom limb pain?
So phantom limb pain is definite because you can demonstrate the lesion. There's a nerve that's transected.
But it's healed over. I mean, it's...
But there's a nerve injury. You have loss of functional nerve distribution.
Okay, I'll accept that. I have a quibble with that.
Yeah, I understand. But within this weird arguing about angels and a pinhead,
Got it.
that's the way they would be able to say that.
Got it.
Another thing to think about is that sorting out what's going on with the neurologic illness and the underlying disease may be kind of a separate process from effectively treating the patient's pain. And as we kind of talk about this more, you'll see why that is. And then finally, I've been involved with new drug development for almost 20 years now, and there's not a single drug, not a single treatment on the market They came because some smart person had an idea about a model they saw and developed an intervention based upon that understanding of physiology. Not a single treatment we have in 2015. Everything that's looked promising has failed at a phase 2 or phase 3 of clinical trials. Nothing has come to reality. So despite our huge advancement in understanding of neurophysiology, nothing has transferred from that bench to the bedside yet. Kind of frustrating. Okay, common diagnoses. The top 4 have FDA-approved treatments, and the top 2 represent something like 90% of the clinical literature on neuropathic pain. Postherpetic neuralgia and diabetic peripheral neuropathy. And we'll talk about why that is in a couple minutes. There's a bunch of other ones which are in the group there, and which can be seen by you in clinic or encountered in other settings. First thing we're talking about is diabetic peripheral neuropathy, and this is back a million years ago when I was still living in Pennsylvania, kind of when I was just starting to get interested in neuropathic pain. So my wife's grandfather is this gigantic guy, worked in a steel mill in Johnstown, Pennsylvania. Sitting down at his kitchen table, and he says, "Brett, tell me why a guy's feet would burn at night. I go to bed, and just as I'm starting to fall asleep, it's like there's a torch on my feet." And I had an idea why that was, but I started talking to him, and he had explained this to his doctor 2 years ago. His doctor had said, "Oh, that happens when you get old," and totally ignored him, did nothing. No workup, no examination, nothing. I kind of started probing a little bit, said, I'm not going to be your doctor, but I can ask you a few questions. He had no other medical problems other than a little bit of hypertension, treated with like diuretic or something. He was 6'2", very, very physically active guy. I did a kitchen examination. I used a butter knife to check his reflexes, which were absent at the ankle. I checked his sensation. He had a loss of sensation to cold, to touch, and to the tines of the fork poking him. I said, I think I have an idea what you should have. You should go to your doctor and have some basic lab work done and work things out. So we went to his doctor. In the first step, the doctor ordered was an EMG. Didn't order any labs, first an EMG. Guess what the EMG showed? Sensory motor peripheral neuropathy. Not surprising. Oh, look, and then here's the fasting glucose, a little bit high. There was no hemoglobin A1C back then. Eventually it was diagnosed with type 2 diabetes. I had to call the doctor like 5 times, finally gave him on TCA. He was totally happy with that. Low dose TCA, he was fine to the end of his life with that. So diabetic peripheral neuropathy is anything that's a neuropathic pain, nerve damage associated with the diabetes diagnosis. And it appears to be something about the elevated glucose or the way the body handles it that is an underlying problem. And there's pretty good evidence in animal models of animals that exhibit a lot of pain behavior, that there's clear changes in spinal cord physiology in the animals that show more abnormal behavior than those that show less abnormal behavior. So it's not just a peripheral damage, this changes elsewhere in the somatosensory system. It's a pretty big deal. Around 4 million Americans have it. And it's somewhere between 1/4 and 1/3 or so of people with type 2 diabetes end up with painful diabetic peripheral neuropathy. Major risk factors, of course, diabetes and how well controlled it is, how long you've had it. Other things are smoking, height, age, weight, alcohol, hyperlipidemia. And if you have the painful version of diabetic peripheral neuropathy, you're at increased risk for amputation, multiple other complications associated with the diabetes, impacts quality of life, which I'll show you in a second. There's a whole bunch of different diabetic peripheral neuropathies, but usually when we talk about is this one. This is the one I see in the pain clinic setting most commonly, and this is what people usually are thinking about when they see a patient with diabetic peripheral neuropathy. This is the kind of thing you guys think about. I don't think about this part so much. I think about more of this. This is a common question about, doctor, why do I have pain? When you think for diabetic peripheral neuropathy, that's kind of straightforward, and there's a reason it's studied quite a bit. It's common, and it's relatively easy to make the diagnosis. Do you have diabetes? Do you have peripheral neuropathy? If we do a quick little screening, we find anything else that would cause peripheral neuropathy, you didn't work in a heavy metal factory or something, it's pretty easy to come to the diagnosis. That's why it's studied so often. But we ask, why do I have pain? Different story. Because most people who have diabetic peripheral neuropathy don't have pain. They just have deficits. The severity of the pain does not correlate at all with severity of damage in the periphery. Those who have pain are more likely to have sleep disturbance, mood issues, decreased activity. They're increased risk for falling and have other pain issues. And it turns out all those things are risk factors for having pain too. So if you go to a mood disorders clinic and survey them and ask them about their pain, and you go to a general internal medicine clinic or family medicine clinic and do age-matched controls, you'll find more pain in the mood disorder clinic. Most patients in the United States are not prescribed effective medications at effective doses for painful diabetic peripheral neuropathy. Most patients don't receive effective nutritional consultation. Poor glucose controls are risks for getting it. Obesity and hyperlipidemia are risks. Obesity is kind of an epidemic in the United States. And people who are overweight and don't exercise are increased risk. Taller patients are increased risk. There's definitely genetic factors. So when that patient's sitting in front of you and saying, why do I have pain? Yeah, I don't know. Lots of bad luck. Things just happen to work out that you were the one that got the pain. It's hard to know exactly. What we do know is it definitely impacts quality of life. So this is kind of the first round of studies I did. It was involved with where we looked at patients with neuropathic pain and looked at quality of life. The way we did these studies was patients with an established diagnosis of diabetic peripheral neuropathy coming to a physician's office were asked, hey, would you like to fill out some questionnaires and let's look through your records about your diabetic peripheral neuropathy? They said, sure. So we found that those with more pain had more depression, more anxiety, more sleep disturbance, and more impaired function, which sounds kind of obvious, but we couldn't find any other references to this previously. And then we looked at their records and showed that they used the healthcare system more often, had more visits, had more medications, were less likely to be working, had less productivity at home, were more likely to have a spouse helping them with things around the house, for instance, more likely to miss work, etc. Many of the patients were prescribed ineffective medications, which we'll talk about a little bit later, and that a subsequent study showed that if you improve people's pain, a lot of those other things got better as well. So the pain seemed to be the driving force behind a lot of those things. And then while I was standing at one of those posters, a guy came up to me and said, hey, I have access to this database. It's a really cool database. It's patients online who said they want to take health surveys. And to be part of this database, they have to enter a bunch of stuff about their health. We've identified several thousand people with diabetes. I bet we could find people with neuropathy in that group and ask them questions. So we started thinking of a bunch of weird questions. And one of them was, if you could be pain-free for an hour, how much of your life would you trade away to be pain-free for 1 hour? A weird question. I've never seen that anywhere else in the literature. And if people rated their pain as severe, which was greater than 7 out of 10, they'd trade 22 hours for 1 hour of pain relief. Now, is this a very scientific thing? Not at all. But does it give you an idea of how desperate these people are? I think so. 22 to 1 exchange rate, that's pretty high. The downside of doing studies like this is this was funded by some company that had one of those great ideas that was a lab idea. It was phase 2 trial. Didn't get past that. They're starting to be really interested in diabetic peripheral neuropathy pain. But then when their drug failed, they withdrew all the interest. They took away the data I didn't already have in my hands from me, so it never got really published. It's just abstract. And the other thing about diabetes is kind of interesting is that we could talk about treating the pain, but it can't be independent from health. For diabetes particularly, you have to treat the diabetes well and treat people's health well. Get them to exercise, get better control of their glucose, better control their diet, better control their lipids, not smoke, a bunch of other things that are not part of our usual sort of way we think about treating patients. But it's inherent with this disease. Yes?
Do we have terrific evidence that says that matters for pain?
We have some evidence to say that matters. The question is, do we have terrific evidence that matters for pain? And there's a little bit of evidence that says that better control leads to fewer neuropathy symptoms, and not much data about reversing any symptoms. It certainly doesn't reverse progression. The other well-studied area is zoster, herpes-zoster-associated pain. Not nearly as many patients have this problem, and we could spend a lot of time talking about what's going to happen with vaccinations in terms of herpes zoster and postherpetic neuralgia. First thing is, what is postherpetic neuralgia? The classic definition in the literature is one of the dumbest definitions you can ever think of. 3 months after healing of the lesions. So if you talk with a patient with postherpetic neuralgia and say, hey, when did you get your herpes zoster or shingles. They can tell you when they got their shingles. I was at this party and whatever. They can describe when they got the rash. If you ask them, what day did your rash heal? I don't know. Your rash heals slowly over a period of weeks, right? It doesn't like it heals. But the classic definition is 3 months after healing of the rash, which is a stupid definition. So I think a definition that works better is about 4 months after they had a herpes zoster, start calling them PHN. So that's postherpetic neuralgia. And postherpetic neuralgia pain in general is a little bit different than diabetic peripheral neuropathy pain. It has more allodynia, so normally non-painful stimuli is painful, more burning component, and it can have a lot more variety. Some people are completely diaphragmated and painful, some are extremely sensitive, won't let their shirt touch their chest wall. This is that spectrum of things from acute herpes zoster to kind of the subacute herpetic neuralgia to PHN. I'm going to skip over that. This is what if you just look at everybody going through primary care and follow them when they have a herpes zoster outbreak. Their average age is going to be in the 60s or 70s. Some older, some younger, but usually 60s and 70s. I think the study was 66. And you see that typically pain starts out relatively high. Pain above 4 out of 10 really starts impacting quality of life in general. And after a couple of weeks, it's for most folks getting better and kind of wanes. I'll show you later with a scale that's not weeks but months what the people that linger. And it impacts quality of life and function for a while, and most people are getting better. So there was a person I collaborated with, a guy named Bob Dworkin, who's from the University of Rochester, put together this very interesting panel of folks to talk about how to treat herpes zoster. And it was people who were infectious disease specialists and neurologists and pain specialists from in Europe and the United States. And the treatments are pretty simple, these guidelines, which is first get seen. And then when you get seen, the number one thing to do is decide to give them antivirals or not. And the number two is decide is it complicated or not complicated. Those are really the two things you have to decide right away. If it's uncomplicated herpes zoster, if they're over 50, just give them antivirals. If it's really straightforward, they're under 50, don't give them antivirals. And if it's really complicated, get a consultation with a neurologist, with an ophthalmologist, with an infectious disease specialist. And then if they're not getting better, and not getting better either because the rash is not healing or because their pain is poorly controlled, within a few weeks you should get a referral. This is over a broader spectrum of time. This is from a review article in New England Journal of Medicine just recently. And it shows that if you look at 6 months out, the changes start getting less dramatic. So I just saw somebody in clinic today who was exactly 6 months out. And his pain, last time I saw him, was 4 out of 10, now it's 2 out of 10. And he attributes to all kinds of things, but I know the truth. It's probably partially a lot of natural progression of condition. He's getting better, right, for multiple reasons. There's this little subset of patients that never get better. And after about a year, your chance of having substantial improvement starts getting a lot less. And there's this golden window of time to kind of get things better. So we look at who gets PHN and then who's more difficult to treat. So most people who have herpes zoster, the lesions heal, the pain gets better. So if you look at people who have a more extensive rash with more lesions, severity of pain, they describe the pain in kind of neuropathic characteristics. It feels numb, tingling, that kind of thing, burning. They're more likely to have ongoing pain. If they have higher level of distress associated with initially, they're more likely to have ongoing pain. And if they're older, they're more likely to have ongoing pain. The age thing has been recognized forever. People over the age of 60 to 70 have a much increased risk as compared to people under the age of 50. Yes?
Is it not associated with where the rash is? I was under the impression
Yes.
that people with facial herpes were more likely to get pain. Is that not true?
So the people with non-thoracic dermatomal involvement are more likely to have complications of all sorts than people that have truncal thoracic dermatomal involvement. That was on the slide I skipped earlier. It said that. So it's exactly right. Non-thoracic dermatomas, higher risk, including face. So when you see them in clinic, they're not going to look that impressive in terms of their physical exam. They'll have interesting focal, usually dermatomal sensory losses and or extra bonus findings of hyperalgesia or allodynia. They can describe the pain all kinds of different ways. It's important to kind of look for secondary musculoskeletal pain around the area and to note also that the area of sensitization can extend beyond the area of initial infection. So if you map out where their rash was by looking at scarring, then you do a careful sensory exam, They often have hypersensitivity above and below that with hyperalgesia to pinprick, allodynia to brush, light touch, that kind of thing. What you can't see is what's going on inside. And these are some really cool autopsy findings from Canada, from a guy named Peter Watson. And this is a person who had severe postherpetic neuralgia who died. They did an autopsy, and what they showed was that around the dorsal horn, there's all this proliferative scar tissue surrounding it. And I mean, it's the dorsal root ganglion, and then in the dorsal horn, there's atrophy of the dorsal horn itself. So definitely central nervous system consequences of this peripheral rash.
Do you know how long he had it?
This person was many years. Many years
Many years
persistent.
later?
Yeah, it was a long time later. And then this is the one exception I can think of about the severity of nerve damage correlating with severity of pain. And this is work from Anne Louise Oaklander, MGH. And she took, this was a long time ago now, but she did skin biopsies and counted small fibers and showed that loss of small fibers in the periphery in the distribution of a previous shingles outbreak was a good predictor of who got pain and who didn't. So the people with red have pain, the people with blue don't have pain, and the height of the bar tells you the density of the nerve fibers. So the greater the loss of the fiber, the more likely they're to have postherpetic neuralgia. So those earlier studies looking at quality of life led us, a group of us, to kind of think about doing different things. So we had this series of studies that I've totally forgotten why they're called BEAT studies, to be honest. But it was 624 subjects, about 100 per different diagnoses. And they're the same kind of thing. They would come to the doctor's office. We'd ask them if we could have them fill out a bunch of surveys and look through their medical records. But these people, we had better database access to them. And so we published a couple of big papers looking at the whole 624 of them, and then some disease-specific papers. And I'll show you a couple of the key outcomes. So this first one I think is really, really cool. It is looking at pain severity and healthcare costs. The people that have mild pain, their direct and indirect costs tallied up was $17,000. People with severe pain, essentially twice that. So as your pain intensity goes up, your cost of care goes up, and your loss of productivity goes up as well. And this is looking at a variety of things related to work on this other paragraph here, showing again, the other side of the slide, again showing that pain intensity is one of the best predictors of work impairment. And then we looked at multiple measures of quality of life and showed again that pain severity correlated with impaired quality of life. So this separate, just pain intensity. If your pain's less than 4, 4 to 7, more than 7, quick snapshot, you can tell a lot of things about those patients. Treatment. So the reason I show those chronic pain slides at the beginning is I think ongoing neuropathic pain should be treated in many ways like other chronic pain conditions, which is think about the biopsychosocial model and just decide what patients need and match treatments appropriate to that patient. Things from the medical sphere, from the psychological sphere, from the rehabilitation sphere, and taking into account all these background issues. Their previous experiences, their genetics, overall health, insurance, work, disability, money, family, leisure, meaning, a bunch of other stuff factor in there. So there isn't any one treatment path for any one condition. It really has to be kind of individualized. And people have talked for ages, since I've been doing interest in neuropathic pain, about mechanism-based treatment. We figure out the mechanism, and then we target a treatment to that mechanism. It sounds really good. There is very, very skinny data to back that up. So there's not really great evidence that our physical exam or any diagnostic test tells us a physiological understanding of the pain mechanisms itself well enough to help direct a specific treatment. And not only that, since a lot of the medications we give people and treatments we give people are relatively non-specific, they're not as directed as we think we are. So I'll show you an example in a second with tricyclic antidepressants. So if you look at medication options for neuropathic pain, those with the best evidence are listed on the left. Antidepressants, specifically tricyclics and SNRIs, gabapentin, pregabalin, carbamazepine specifically for trigeminal neuralgia. Opioids and tramadol have a fair number of short-term studies, and the topical lidocaine patch. Everything else is much less evidence and more conflicting data. And then you look at reality. If someone comes to a doctor's office, they have a diagnosis of neuropathic pain, the two classes of medications they're most likely to be on are NSAIDs with not a single clinical trial to support them, not in any guidelines anywhere. And then another shocking, surprising one is SSRIs, if they have persistent ongoing pain. SSRIs have like a couple of modest, crappy trials that show potential something, but multiple failed trials and multiple unpublished studies in the early 90s when the SSRIs were coming out, showing no efficacy. And then, this is a really cool study from Bob Dworkin. They looked at people being treated in community settings for postherpetic neuralgia, looked at the medications they were prescribed, and only 1/4 of them were on a first-line agent. So they're equally likely to be prescribed something not even on the list or farther down the line. So only 1/4 of them are getting appropriate treatment. So if we turn to kind of guidelines to help us guide us, there's a whole bunch of them. And the guidelines are made by a bunch of different people. And sometimes who makes the guideline really matters, especially depending on what they look at. So this is a table, which I don't know how it projects, of neuropathic pain guidelines kind of around the world. There's only one treatment that is common to all the guidelines, and that's MS. Which is interesting because there are no large studies of tricyclic antidepressants. I'll show you like one of the largest, and it's not very big. And everything else is variable depending from place to place. And some of it has to do with approval in different parts of the world, and some of it has to do with cost, and some of it has to do with the way people look at the evidence differently. When you think about guidelines in clinical trials in general, there's a huge bias towards looking at painful diabetic peripheral neuropathy and PHN, because they're easy to diagnose and easy to study compared to other things. Many of the common conditions with neuropathic pain are studied, and the clinical trial data is based on subjects who are definitely not patients. And they really assess very limited outcomes, usually basically a visual analog scale or a verbal analog scale, some other kind of pain scale. And the assessments are really quite short term. They really don't show what happens over long-term treatment. And the biggest studies, the best funded studies, are all from pharma, all of them, every single one of them. And the FDA doesn't fund studies. The NIH won't fund drug studies that are just drug studies. So there's no other real sources for big pots of money to study these things. There's minimal data about combination therapy, which is the reality in clinical practice. And if a clinical trial is absent, particularly if it's older, you're not going to find it in the literature. Right? It gets buried. Lots of detail is missing. And when you think about things that aren't studied, there's a lot of things that we know are good for people's health that are really not studied for neuropathic pain very well at all, just completely ignored. And you think about who comes into a clinical trial. So how many of you have done clinical trials of an investigational drug or product? Yeah. So patient comes in, they have whatever your condition is, MS, diabetic peripheral neuropathy, whatever. That's not good enough. Then they have to be a really good patient with that, right? They have to not have other issues, they have to be totally compliant, on and on and on. So they restrict their comorbidities, they restrict like renal impairment, hepatic dysfunction, etc. They make sure they don't have other pain conditions. They have to be compliant. They can't have too high a pain or too low a pain. They have to be just right, like very Goldilocks-like when they walk through your door. They don't look like my patients. My research subjects are not my patients. They are a different patient population. So when I take data from those subjects and apply it to the real-life patient sitting in front of me, it's a bit of an abstraction. So people recognize this, and there's two groups, and actually a person in my department here is one of the co-chairs of both these groups. And that's Dennis Turk, who was my colleague a million years ago at the University of Pittsburgh, and now he's my colleague again here in Seattle. The first group was called Impact. It looked to try to make clinical trials better, and then it moved on to this group called Action. And they're setting out standards for analgesic trials, and the idea is to make the trials broader. And they basically have the FDA, NIH saying, hey, industry, you're going to be spending millions of dollars in clinical trials. Why not gather some stuff that's going to forward the science in this area as well and help us understand outcomes beyond what you need just for drug approval? In fact, we will be more supportive of those kind of studies than ones that are just focused on the minimum for drug approval. And people are starting to respond. So there's a lot more quality of life, a lot more functional assessments, a lot more looking at kind of tiering with different types of patient groups, et cetera. So things are changing, and I think in the future, there's going to be a lot more clinical trials that have broader outcome measures that look at broader patient populations and ask more interesting questions. So let's talk about some of the treatments real quickly. Antidepressants, there's only one FDA approved for treatment, and that's duloxetine for neuropathic pain, and that's for neuropathic pain associated with diabetic peripheral neuropathy. The evidence is considered to be strong for tricyclics unless you're the Cochrane Review and you look at things, they don't consider it to be so strong. Nothing's really been shown to be superior to TCAs though, but the problem with TCAs is that they're often underdosed, they require titration, they have drug interactions, and multiple contraindications. The other thing is when you prescribe someone an antidepressant, you kind of have to have that discussion about, no, I don't think you're depressed, and that's causing your pain. This really is a pain medication, here's why. And you have to get them that in a convincing, real way. So the mechanism of action we've all been taught about is the one here, over on the left, with the reuptake inhibition of serotonin and norepinephrine. But if you start looking at the tricyclic antidepressants, they do a whole bunch of other things that are potentially analgesic. So I can do a nerve block in a rat with amitriptyline. If I inject amitriptyline on the sciatic nerve, their leg will get weak. And that's because of the sodium channel blockade. So these drugs do a bunch of other things that are associated with pain besides just norepinephrine and serotonin reuptake inhibition. So why it's working in the patient in front of you, who knows? And for the for the tricyclics, it may be this combination of multiple mechanisms that lead to them being effective. So the best and most famous clinical trial ever of the TCAs for diabetic peripheral neuropathy is published by Mitchell and Max a long, long time ago in the New England Journal of Medicine, 1992. It was also one of the studies that showed lack of efficacy for SSRI. So it was two parallel studies. This is disipramine and amitriptyline. Give them to the patients, the pain goes down, they wash them out, they cross them over, the pain goes down again. No discernible difference between the two groups. This is placebo versus fluoxetine. Initially it looks like, oh, fluoxetine's effective. But then they cross over, now the placebo's better. So what did Mitchell and Max do wrong in this study? He didn't exclude depressed patients. When he went back and analyzed this, he discovered that for the TCAs, it didn't matter whether you were depressed or not. For fluoxetine, the only people who responded were the depressed patients. The patients whose depression got better, their pain got better. For the people who didn't have significant depression, the fluoxetine did nothing, meaning it didn't have any independent analgesic effect, which is the general take on SSRIs. You can use them to treat depression, don't use them to treat pain. It's a waste of time.
And it looks like there was no placebo in the amitriptyline.
No, there was two studies done at the same time in a parallel fashion. So it wasn't a direct placebo comparison over there. You're right, it's a very interesting study design. It's kind of two studies at once. So duloxetine was developed by Lilly in Indianapolis, and they weren't even thinking about diabetic neuropathy at all. And all the clinical trials were designed by psychiatrists. It was developed as an antidepressant. They figured out that it seemed to be analgesic in animals, and sure enough, it was in people too. I was involved in the study. We had access to a database with millions of lives, and we started looking, kind of being really restrictive and looking at patients who had a diabetic neuropathy diagnosis and who had been prescribed medications in this 12 months before. And then we started looking at people that had TCAs, and then we could look at all their other healthcare things. And then we took the package insert for each of the drugs and looked at the relative contraindications and contraindications and looked at effective doses from the literature. And basically, almost half of them had at least a relative contraindication of being on the drug in the first place. And the average dose was like 24 milligrams. And for diabetic neuropathy pain or for any other neuropathic pain, 25 milligrams is like the lowest dose that's ever been shown to be effective. So most of them were prescribed a subtherapeutic dose, and at least half of them had at least some reason to maybe not prescribe it. Let's skip that. Skip that. Let's talk about gabapentin a little bit. Gabapentin, complete serendipity that this drug is an analgesic drug. I helped design the trials in 1998 that were published in JAMA. Were really, really kind of fun stuff for diabetic peripheral neuropathy and postherpetic neuralgia. Here's a postherpetic neuralgia study. This was pretty interesting. The average age is 71. Within 2 weeks, we pushed the dose to 3,600 milligrams. There was no difference in dropout between placebo and active treatment, which is amazing. There was a difference in dizziness and a few other side effects, but actual dropout, no. Separation of pain within a week, and persistent pain relief. It didn't matter even if they had long-term pain. The world was very, very different for recruiting subjects back then, because in the 1990s, if you went to your primary care doctor and said, I have pain after shingles, the primary care doctor would say, I'm sorry about that, there's nothing I can do. It was very, very easy to recruit patients because no one had ever been treated. That's different now. Pregabalin came out, and the word on the street was always just very similar to gabapentin. And if you're at Northwestern University, you love pregabalin because they've had more than $1 billion of royalties from this drug. It's a very helpful thing for Northwestern University. But I think there's a little bit of data that says a little bit different. So it has linear absorption across the doses. So if you double the dose, you double the serum level, which is not the same thing as for gabapentin. It's effectively dosed twice a day as opposed to 3 times a day. It can begin working within 1 day. Has better evidence for reducing allodynia. It can be effective in treatment-resistant patients, and a bit more time I'll tell you about how that study design was that showed that. And also maybe more opioid-sparing than gabapentin. There's a bunch of sort of observational studies that would kind of lead a little bit of evidence to make you think that, lend some evidence to make you think that maybe it's a bit more opioid-sparing than gabapentin. There's a bunch of topical treatments, but the only FDA-approved one is lidocaine patch. Capsaicin is available over the counter. Plus also there's a topical treatment, the 8% Utenza patch. Have any of you had any familiarity with that? It's brutal. So if you go to the drugstore and buy capsaicin, it's 0.075%. This is 8%, 100 times as potent. So you put it on you map out the area of the PHN, clean the area off, put local anesthetic on, let it sit there for an hour, wipe it off, cross your fingers, and put the patches on, and leave the patches on for an hour. In around 10% of patients, it's sheer torture for the entire hour. It's like a burning fire thing. Everybody else seems to do okay. You take it off after an hour. What do you think their skin looks like after 8% capsaicin? Salmon flesh. That's what it looks like. It looks pink and kind of mottly and raised up. It looks horrible, like every single time. And then you hope that the action of that high-dose capsaicin, which basically deactivates C fibers, relieves their pain. And in a little subset of patients, it definitely does. And it can last for up to 3 months. So it's a pretty cool treatment. It's also an example of pharma perils. So 8% capsaicin was developed in California by a new company, successfully brought a product to market. They invested hundreds of millions of dollars in this product. The company went bankrupt because it was such a pain in the butt to actually use. And the remains of the company were sold for single-digit $1 million to somebody. So it was hundreds of millions of dollars down the drain for a potentially effective treatment. There is also an opioid FDA approved for neuropathic pain. That's tapentadol ER, which I'm sure that very few of you have ever prescribed. It's a really pretty cool drug. It's an opioid analgesic that has norepinephrine reuptake inhibition as well. I'm going to skip past this. Another interesting thing is this idea of graded motor imagery. Are you guys familiar with this at all? So evidence for stroke, evidence for complex regional pain syndrome, some evidence for phantom limb pain as well. The world's expert in this was here a month or so ago, gave an endowed lectureship and talked with physical therapy students. It's a really cool approach to reorganizing the cortex for patients with unilateral neuropathic pain. There's also pretty good data for physical therapy in fall risk reduction for patients with peripheral neuropathy. So I think it's definitely an underutilized treatment modality for folks. TENS units have a shocking semi-endorsement from American Academy of Neurology, which I find surprising. There's a little bit of data about spinal cord stimulation, which we'll talk about in a second. Not much in the way of CAM data. Now, I'm an anesthesiologist by training, even though I'm talking about neuropathic pain. So I was trained to do procedures. I do procedures. Procedures are pretty interesting. You know, the patient just sits there and does nothing. You do something to them. To the patient, there's all kinds of good things. There's doctors taking me seriously. They're going to take my pain away. They must really believe it's a big deal. I don't have to do a damn thing but lie here, and boom, I walk out pain-free. It's pretty amazing. So it's reimburses well, all kinds of good things, right? There's lots of downsides. The evidence is really quite scant. Why are we doing these things? I saw someone yesterday with pain from head to toe, BMI of 43, unable to stand up because of poorly controlled diabetic peripheral neuropathy, just had a series of lumbar epidural steroid injections someplace else for one of the many pain problems she has. What a waste of time. So they're expensive. The evidence isn't very good. They definitely have risk, and some people don't really assess the patients and know them very well. It may actually distract from better treatment and waste money and resources. So
Any studies on acupuncture?
there are not very good studies for diabetic peripheral neuropathy or PHN. There's like little exploratory studies, but none of the high quality sham studies are with those conditions. They're more like back pain. Good question. And I'm sorry I forgot to repeat the question. The question was about acupuncture. So the International Association for the Study of Pain put together another guidelines committee to look at interventional management and looked at all the different things we could think of that were used on an interventional basis for treating neuropathic pain. We came up with 4 weak recommendations for epidural injections for herpes zoster, steroid injections for radiculopathy, spinal cord stimulation for failed back surgery syndrome, which is a horrible term, and spinal cord stimulation for complex regional pain syndrome type 1. So I do spinal cord stimulation, so I thought I'd talk about that a little bit. Leads are placed in the epidural space. Leads are positioned to provide paresthesia over the painful area. They have multiple contacts. The patient has multiple programs. If the patient has a favorable trial, meaning they have a dramatic reduction in pain, improvement in function during temporary placement, then they get a permanent system. The target for the spinal cord stimulation is the dorsal aspect of the spinal cord, and it's going to modulate the sensory systems. The first spinal cord stimulator was placed in the 1960s, shortly after the gate control theory was published in Science by a neurosurgeon in Denver. It evolved over time so that now the leads can be put in percutaneously, not just by neurosurgeons. And the systems have changed dramatically. So newer systems have up to 32 contacts. Some of the systems are MRI compatible. Some of them change stimulation based on the patient's position. Some of them have remote controls. They're all rechargeable for the most part. And there's a bunch of new stimulation parameters coming out, including the dorsal root ganglion, and then high-frequency stimulation above sensory threshold, and other programs that the patient doesn't actually feel any paresthesias. One of my colleagues in Portland came to us from Hopkins, and he had a lab where he took little rats and put miniaturized spinal cord stimulators in them and showed that these different stimulation parameters actually stimulate different populations of nerves in the dorsal horn and actually had different physiologic manifestations. So different stimulation equals different stimulation and different changes. There's multiple actions with spinal cord stimulation, which I'm not going to go into now. A little bit about the data. So this is an older study now from Johns Hopkins. Patients who had spine surgery, had ongoing pain, which was thought to be primarily radicular and primarily neuropathic in nature, went to a spine surgeon. The spine surgeon re-imaged them and said, I think you need another spine operation. At that point, they're randomized to either get that other spine operation or to get a spinal cord stimulator trial. If they had a successful trial, they're implanted. And the big thing is that those who were in the spinal cord stimulator arm had more likely to have successful treatment, which meant 50% reduction in their pain. That's 9 out of 19. Used less opioids, and less likely to say, I'm not satisfied with this, I want to cross over. And it was cost effective, no matter how we looked at it, over the period of time. Yes?
Sorry, did you define pain of spinal origin?
Their version of that was they had some type of spinal pathology that was thought to be the source of their underlying source of their pain.
Degenerative changes.
Degenerative changes, herniated disc, instability,
Yeah,
a whole bunch of things. A whole bunch of things, but it had to have primarily radicular nature to it to be studied. This is that's the biggest, that's the first big back pain one. There was another one subsequently that I won't show you because we spent a long time on spinal cord stimulator data. This is the CRPS study published in New England Journal of Medicine a long, long time ago in 2000 with technology that is nothing like what we have today. This is the only significant spinal cord stimulator study published anywhere in the world not funded by industry. 54 subjects from the Netherlands, randomized 2-to-1 to stimulation versus usual care with intensive physical therapy. And they showed multiple benefits over the first couple of years in patients implanted with spinal cord stimulation. And it was an intent to treat analysis. So if you're randomized to spinal cord stimulation and you had a trial and your trial was unsuccessful, you were counted as a spinal cord stimulator patient. So when they looked at patients at 5 years, the benefits had waned. But then they thought about how we use spinal cord stimulation in reality. The trial screens people. So I wouldn't consider a patient who failed a trial to be a spinal cord stimulator implant failure, but they were considered to be a spinal cord stimulator implant failure. So I looked at sort of the as treated group, the people that actually got a spinal cord stimulator. The majority of them were satisfied. There weren't that many patients around for analysis, but 95% of the ones they could contact said they would repeat the procedure for the same outcome. Pretty good. So when I was at the University of Pittsburgh, we had a study looking at spinal cord stimulation and sympathetic function of upper and lower extremities. We did QSART testing and showed that patients that had rated their spinal cord stimulator as being successful for treating their pain, that had CRPS and had abnormal QSART, had normalization with QSART. And we had talked about that when I came to Portland with this really cool case of change. This is a woman with Raynaud's. She'd already lost some fingers. She was looking pretty white and pretty bad. This is the day after we put the trial leads in. Complete change. She's done fantastically well. So she had an old system that required battery change. She came in with battery dead, fingers were white, put a new battery in, back to looking red. And there's a couple other case reports of similar kind of physiologic changes. And then if you look in Europe, what spinal cord stimulation is used for, it's used for completely different things. It's used for treatment-resistant angina and peripheral vascular disease primarily. And with really good data to support it in those patient groups, and actually better data than for the pain things we use it for in the United States. Epidural for herpes zoster. So the idea of this is you give an epidural injection of local anesthetic and steroid at the dermatome involved, and it can reduce pain acutely and may have benefits long-term in helping promote healing, reducing the time of severe pain, etc. There's 3 or 4 studies that are prospective and large and interesting and good. And then there's the biggest study with the best publicity in Lancet, which was not a very well done study, but I know the author quite well. It's the PINE study. The author is a guy named Bert Van Wyk. He practices in the Netherlands, and I asked him, like, why did you design the study this way? It's not a very good treatment. He said, well, here's a story. We had half of the population of the Netherlands as our study population. Pretty big population. And the patients, the agreement was they would go to their local hospital, get the herpes zoster diagnosis. If it was a thoracic dermatome and the pain was above a certain level, they would be asked to participate in the study. And they wanted the study to be able to be done in these little hospitals throughout the country, throughout the country. So rather than what all of us want to do, which is place an epidural, place a catheter, give more continuous treatment, he wanted something simple and easy. It was a single injection, local anesthetic and steroid, that's it, one-time shot, early on in the course of the herpes zoster. And the effects were relatively modest, but when they looked at it in terms of cost effectiveness in the Dutch health system, it was still a cost-effective treatment. And no one does it this way, but it's an example of, if you look closely, you can get a good outcome. When I first came here to the University of Washington, I had a patient presented this way. She had presented with a rash on the right side of her face, almost up to her ear. She'd been she'd been diagnosed with Ramsay-Hunt syndrome, which was an inaccurate diagnosis, but that's what the diagnosis had been from her primary care physician. She'd been treated with oral steroids, gabapentin, lidocaine gel, and patch. I saw her, she canceled a trip, she was miserable. When I examined her, her dermatomes were really, it was nothing to do with her ear, it was really more primarily C3. Pain was severe, she was desperate, function was severely compromised. I gave her pregabalin. I set her up for a cervical epidural steroid injection, which we did, and I got a message from her last week, so now more than about 2 months out from her treatment, she still is essentially pain-free. Just a little bit of itch in the area, but that's it. And here's how we do that epidural. So putting a needle up at C2, C3 is kind of tricky, and there's not much space. So the way I avoid that is to enter down lower, down here, the T1, T2, and then thread a catheter all the way up. And this darkness here is the contrast spreading, covering C3 up to C2 and then down to C4. So you can make it directional and aim it for wherever you want to, and you put nothing sharp up there. So there's a bunch of different treatment options for neuropathic pain, and it's difficult to match things. You have to make it specific. I'm going to skip that and just talk about this, which is, I'm not a diagnoser, I'm not a treater of the underlying disease, but I love treating neuropathic pain. And I think my goal is to kind of develop a collaborative approach with people that are seeing neuropathic pain patients in the clinic, and then put together a team approach for taking care of them. And have treatment that really is based upon what the patient needs. If they're interested in CAM-oriented treatments, we can provide them CAM-oriented treatments. If they need help with behavioral interventions, we can provide that. They need to be able to function better and not fall and break their leg or break their hip, we can help with that. And if they need procedures, we can help with that. I want to really try to have it under one umbrella and one place. And I would love to work with you guys and make this a collaborative event. So that's my talk. Thank you very much. And I'm very happy to answer any questions. Yes?
Did you work with psychologists in that? Or circumstantial?
Yeah, so the question was, do I work with psychologists in our clinic? And the answer is yes, and then I'll tell you the true answer. Okay, so when I was in Portland, we had 5 times the FTE of psychologists as we have here at University of Washington. Here we have parts of several psychologists, but they add up to not a huge FTE number. We are planning to expand that to make that more available because it's a really important component of treatment, absolutely. And we also have, unlike a lot of places, we actually have psychiatrists in the pain clinic, and we have one psychiatrist whose entire career has been focused on mental illness and pain. So we have both psychiatric and psychological services available, just on a more limited basis than I'd like it to be. Yes?
That's nice, very nice talk. I get asked from a lot of my neuropathy patients about 2 things in particular: cold laser therapy and naturopathic therapies for neuropathic pain. In particular, things like alpha-lipoic acid. What do you tell the patients when they ask you about these things?
So the question was about naturopathic treatments, alpha-lipoic acid, cold laser. Couple things. I tell them that there's not really good data for the cold laser because I have not seen anything really published that looks very convincing for that. There are placebo-controlled randomized trials for both alpha-lipoic acid and acetyl-L-carnitine. I think that's completely reasonable. And I also do think that people that have nutritional deficiencies are more prone to have neuropathic pain. So if their vitamin D is low and their B6 is high and their B12 is low, those are things to kind of normalize. There's a lot of popularity about magnesium supplementation and not tons of great data to support that. I think it's unlikely to be totally harmful. So some of the things they do are kind of a little bit odd, like IV version of some of these treatments, which may be a little bit aggressive. When I was in Portland, there was the National Institute for Complementary Alternative Medicine had applications for center grants, and there's 5 center grants awarded in the country, and 2 of them were in Portland. Tells you what Portland's like. And I was on the scientific panel for one of them, and we did one of the little subsets of studies was looking at traditional naturopathic remedies for head, facial, and nerve pain, and then looking at what they did in the lab. And these were incredibly potent anti-inflammatory concoctions that were incredibly variable from batch to batch. So they went to, there's a naturopathic school in Portland, and went there to the pharmacy and said, hey, make us up, blah, blah, blah. They went out to some naturopath, somewhere else in town and somewhere else, all asking for the same thing, brought them to the lab, and showed huge variability in their effects, but all more anti-inflammatory effects than their placebo control stuff. So these things do something, they're just not very well controlled, and some of them do more than others. Hard to know. I think if someone's oriented that way, and that makes them feel better, and they're not going to get harmed, it's okay with me. Yes?
You talked about low-dose naltrexone.
So the question's about low-dose naltrexone. I think low-dose naltrexone is a real treatment. And it has, prospective data for Crohn's disease that looks promising. It has fMRI changes in patients with fibromyalgia. Some really cool stuff happening at Stanford looking at low-dose naltrexone and mechanism of action. So I think there's something there. I think it's very trendy right now and being used for lots of things, so it's hard to know when it's going to be effective or who it's going to be effective for. I'm pretty sure the truth is there's a subset of patients with sensitization problems that's going to help. Who that subset is, I have no idea. But I think there's something to it. Yes?
So the sodium channel business, I think, is obviously really interesting, and pharma is interested in it because you showed that the TCAs have some effect on it.
Yes.
But one of the amazing things is there are these rare mutations in a specific sodium channel.
NAV 1.7.
The patients feel no pain.
Mhm.
They don't feel pain at all.
Yeah.
Which is incredible. That must be telling us something about a kind of treatment for pain, but I don't know how to capitalize on it.
So a lot of people have looked at that. My disclosure was a phase 2 study with a NaV 1.7 drug. So you can find that by looking at clinicaltrials.gov. So it's pretty cool stuff. And the other thing that I used to do in Portland that I have not been able to do here because of the patient safety committee so far is IV lidocaine infusions. A really, really cool thing. Have you guys read about those or seen those? So the way we did it there was bring someone in, put them on an EKG, start an IV, give them, kind of let saline run for a while until they got bored, and then kind of when they weren't looking, turn on 5 milligrams per kilogram lidocaine and run it in over 25 minutes. And patients who are a non-responder, around 20-25 minutes, they'd say, I feel kind of funny, my pain's gone from 8 to 7.5 or something. But some people, like, my pain went away. I feel, I can't believe how much better I feel. And the effect can linger. And a bazillion years ago, I visited Yale, where Steve Weissman is, this NaV 1.7 guy, and I was visiting for the Department of Anesthesiology, but we had this little neurology discussion about these erythromelalgia patients and their sodium channelopathies that were starting to be kind of looked at by the groups there. And I've had some amazing lidocaine infusion turnarounds. It's really, really cool. Now, what do you follow that up with for an oral drug? That's the question, right? So the carbamazepine is one option, oxcarbazepine is another, and then what people used to use is mixilotine, which is a little bit of a tricky drug to use, and it certainly occasionally can work, but more commonly causes toxicities. So we have not quite found the oral sodium channel blocker that works really great, but there's definitely something there, and there's a lot of drugs under development that are sodium channel modifiers in some way or another. Yes?
So I had a very interesting experience about 6 weeks ago of having zoster,
Yeah.
which was horrible as a person and fascinating for me as a neurologist. But it really wasn't a painful experience at all. What it was a profound, deep, crawling itch.
Yes.
And when I had read about that, or when patients of mine talked about itchiness, I thought, you know what, it's an itch,
Yeah.
put a little calamine on. But this was really something altogether different
Uh-huh.
and nightmarish. Kind of, wanted to crawl off my skin conditions. What makes that difference? Is that just a different population of nerves? And when patients do complain to you about that, what do you treat them differently? Is there something that's more?
Great question. So the question is about painful itch or just unpleasant itch associated with zoster or other neuropathic pain conditions. Well, that same woman that did the small fiber stuff, Anne-Louise Oaklander, oh, I forgot, I'm sorry. I apologize. Sorry. Actually got a grant to look at painful itch and to try to look at that. And when I haven't looked at those papers recently, but when I looked through those, it was difficult for me to determine that there was something really that separate about it. It's really not understood, and no one really knows how to treat it. And sometimes neuropathic agents work. Sometimes sort of distracting things work, like pressure, TENS unit, other things that kind of change what the stimulation that's going on in the area or adjacent to the area. It's a really interesting thing. That patient I treated with the herpes zoster of the C2, C3 area, she was left with an itch that was getting increasingly less painful over time. But she had the itch too. After the pain was gone, she had the itch. It's an incredibly common thing. The other really interesting thing about zoster is it's FDA approved, the vaccine FDA approved if you're over the age of 50. If you have your insurance through the University of Washington and you're between the ages of 50 and 60, it won't pay for it. So you have to spend the money to get the vaccination if you're 50. It's FDA approved, but your insurance won't pay for it. Isn't that wonderful? Yes.
If you think gabapentin and pregabalin have different mechanisms of action, do you use them together?
So the question is about using gabapentin and pregabalin together, and if I think they have different mechanisms of action. I don't think they have different mechanisms of action. I just think that they have different efficacy potentially. And the question is, do I use them together? And not really. I know that they're going to bind at the same place. I know that in some unpublished data from Park Davis from a long time ago when pregabalin was first being developed, that pregabalin would displace gabapentin from the binding site. So I don't think there's a huge rationale to using them together. I think if we took a population of people, no one's done this study, and gave them gabapentin for a couple months and switched them to pregabalin for a couple months and said, which is like their A or B, my guess is that more of them would prefer pregabalin than gabapentin, but a significant subset would say I like gabapentin better. So there's something different about them in the way they do that, just like SSRIs are all the same. They're not all the same. A lot of drugs are similar, but not quite the same. Yes?
Speaking of using two drugs together, using the TCAs and SSRIs together, at least in pediatrics, a lot of folks get really nervous about that. Like, do you do that frequently, or how do you do that, and how do you work with psychiatry?
So the question's about using SSRIs and TCAs together. I don't like doing that. So my general thought is if someone has a depression that really needs to be treated, then I usually try to talk with their prescriber about the idea of using SNRI, so we can try to probably be more effective with the depression treatment and also a chance of working with pain first. And if I do combine SSRI and TCA, then I feel like I must reduce the dose of something. Because I think serotonin syndrome is real and kind of not recognized sometimes. I think seizures are real and they often are recognized. But I mean, I think those things really do happen. And then you throw in a little tramadol, a little something else, and before you know it, interesting things are happening. Well, thank you very much for your attention. I'd be happy to answer more questions.